శివ గారు ఆ ఫస్ట్ది ఒకసారి పెట్టరా, ఫస్ట్ పెట్టారు కదా ఓపీజీది కాకుండా ఫస్ట్ది.
ఓకే. symptoms of fever for 7 days, shortness of breath for 5 days, cough with expectoration for 3 days. History of present illness: fever for 7 days, high grade intermittent associated with chills and rigors, relieved with medication, no diurnal and nocturnal variations. Shortness of breath for 5 days, insidious onset, gradually progressive from grade 1 to 4. That is breathlessness even with rest. No paroxysmal nocturnal dyspnea and no orthopnea. Cough for 5 days, insidious onset, gradually progressive in intensity, associated with sputum, whitish mucoid, moderate in quantity, not blood tinged and non-foul smelling. No complaints of hemoptysis, loss of weight, loss of appetite, chest pain, pale edema, and wheeze. Past history: history of PTB 30 years back, used ATT for 6 months, not known case of hypertension and diabetic, no chronic history. Family history nil significant. Personal history: chotta smoker for 30 years and stopped 5 years back. On general examination, patient is conscious, coherent, cooperative, moderately built and nourished. No signs of pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, and pale edema. Vitals: 86% on room air with 8 liters of O2 with face mask. It is 98%. BP 130/60, temperature afebrile, respiratory rate 30 per minute, abdominal thoracic type. Systemic examination: upper respiratory tract normal, lower respiratory tract. On inspection, use of accessory muscles of respiration seen. On auscultation, normal vesicular breath sounds heard. Bilateral inspiratory crepes present on inframammary, infraaxillary, and infrascapular areas. And bilateral expiratory V's present. Other system examination normal. My provisional diagnosis is pneumonia, PTB sequelae with bilateral bronchiectasis or reactivation of PTB with respiratory failure. Coming to the blood investigations, total WBC counts were 27,000 and urine ketone bodies were positive with RBS 400 mg per dl. LFT, RFT were within normal limit. This is the chest X-ray showing right lower lobe non-homogeneous opacity is present. HRCT chest. Peribronchovascular consolidation with GGO, stream blood nodules in right lower lobe, fibrobronchiectasis in left upper and middle lobe, emphysematous changes in right lower lobe seen. 2D echo normal. Till now, my final diagnosis is right lower lobe pneumonia with sepsis, PTB sequelae, respiratory failure with diabetic ketoacidosis. Coming to the treatment, injection cefepime plus tazobactam 2.5 grams. Injection Derflin 1 ampule IV BD, injection MGSO4 2 grams IV statin 100 ml NS, nebulizations with ipratropium bromide plus levosalbutamol and budesonide, injection Pant of 40 IV OD, tab Lesmo once daily, Mucinex 600 mg 12th hourly, and patient is on NIV PC mode with FiO2 40 and PEEP5. In view of high blood sugars and urine ketones positive, we took the general medicine opinion. They advised IV fluids and human activate infusion according to GRBS. Advised HbA1c and CRP. At around 10 p.m., a patient developed tachycardia and hypotension, and her ECG shows atrial fibrillation. Cardiology opinion taken. They advised Amedron 150 mg start followed by 300 mg IV infusion for 24 hours. And we started NORAD infusion at 5 ml per hour. And this is the ECG, shows atrial fibrillation. And next day, CRP came to be 223.62, HbA1c more than 13. Again, ketone bodies were positive. Vitals same with NORAD 3 ml per hour. Sputum CBNAT negative. After amedron infusion, we started the patient on amedron infusion 200 mg PD. And next day, early morning at around 5 o'clock, ECG shows again atrial fibrillation. We delivered 150 joule shock and advised to cardiology people advised to continue amedron infusion for next 24 hours. After that, amedron can be restarted. On day 3, sputum culture, Klebsiella species isolated, resistant to cefepime, and urine and blood culture sterile. We stopped the injection jobabam and added injection meropenem and linezolid according to culture sensitivity reports. This is the chest X-ray on day 3. On day 4, patient is in hypotension. Same treatment continued. On day 5, we added itraconazole 200 mg BD and injection KCl infusion were started in view of hypokalemia. On day 6, serum amylase lipase were negative, troponin negative. Ultrasound abdomen shows no sonological abnormality detected. Till now, patient had severe leukocytosis and hypokalemia. On day 9, we repeated the HRCT. It shows consolidation in right lower lobe with cavity inside. On day 10, same vitals were continued. Patient is in hypotension with NOR at 2 ml per hour. Her BP shows 130/80. Empirically, we started ATT. On day 8, tab band down 40 mg OD, and sugars were controlled. So we stopped the insulin infusion. We started according to sliding scale subcutaneous. Tab metformin 500 mg TAD and tab tenligliptin 20 mg OD given. On day 11, patient hypotension recovered. So we stopped NORAD infusion. Done. It came to be normal. On day 13, this is the X-ray showing large consolidation cavity on right side, with diffuse non-homogeneous opacities on left side. These are the investigations showing severe leukocytosis. And on 12th November, hypokalemia corrected. On day 15, morning 8 o'clock, patient got desaturated and tachypnic. Her BP 80/60 with 82 liters with 82% SpO2 on 15 liters O2 with NRBM mask. Patient was started on NORAD infusion. The patient condition explained to the attenders. They are not willing for intubation, but they gave consent for CPR. We started CPR. 5 cycles of CPR done. Morning 9:25 a.m. Her ECG shows flatline and patient declared dead. My cause of death, sepsis with septic shock secondary to necrotizing pneumonia. The antecedent cause is atrial fibrillation, diabetic ketoacidosis, PTB sequelae. Thank you.
Anyway, good brief presentation. Now it's open for discussion. You can ask. Yeah. Okay. Let us start. Pulmonology, please. Pulmonology. Yes, sir. Where are your?
Why do you say it is necrotizing pneumonia?
In the necrotizing pneumonia, lung parenchyma are distracted, and there is necrosis inside the lung parenchyma. We see the cavity inside the consolidation. So,
What are the causes for necrotizing pneumonia?
Anaerobic organisms, gram-negative bacilli, the gram-positive Staph aureus and Streptococcus, fungal organisms. Yes, ma'am. Yes, ma'am.
The time of death, so much of progress of lesion of the infection was there.
Yes, ma'am.
Why you did not start fluconazole the first day itself?
We started.
First day when patient came, no, you started empirically some treatment. All diabetic cases, no, better you start fluconazole early. IV injectables.
Itself, we
IV is
started,
available.
Itraconazole, ma'am.
Later you started, no?
Yes.
First day one you didn't start that. It's better all the time now, but diabetic patient they need this antifungal also. That's what.
Majorly, necrotizing pneumonia can be due to gram-negative bacilli. That too.
Okay, let it be.
Species isolated.
I'm not talking about organism, bacteria, but thing is diabetic fungal respiratory infections. Better always go for that too severe infection. Injectable fluconazole is available. That
she is de novo diabetic, ma'am. She is not diabetic.
She said diabetic ketoacidosis.
Yes, ma'am. On arrival, she is not a known case of diabetic, ma'am.
Why she had 400 milligrams? She said.
Yes, ma'am.
400, you said. It's positive ketoacidosis. That's what he said also.
Sputum culture, Klebsiella species
negative.
isolated.
Have you done or not?
CB net done, sir. Sputum CB net, it came to be negative.
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 cases.
Madam, for your question, last question. Normally in community-acquired pneumonia, according to IDSA guidelines, normally we won't use empirical antifungals, madam, because in this case it appears to be progress to necrotizing pneumonia only. Then only we have added antifungal coverage and prophylactic. It is not advised usually, ma'am. According to guidelines, it is not advised, ma'am. According to guidelines, only. Here we have started itraconazole when we have seen progression to necrotization, madam. Then we have started antifungals and anti-staphylococcal antibiotics, ma'am. What are the risk factors for necrotizing pneumonia?
Advanced days, immunosuppressive states, alcoholism, like diabetes.
In these patients, what are the risk factors? Does she have any risk factors for necrotization?
As from she is de novo diabetic and her age is 66 years advanced.
Yes. What is you have started antibiotics. You have given antibiotics initially. You have given cefepime, right?
Yes, ma'am.
So what is the rationale for giving cefepime here? Why do you want to start cefepime for a case of pneumonia?
She had past history of PTB and her ECG shows and her chest X-ray shows fibrobronchiectasis. It is a structural lung disease, ma'am. So we want to cover anti-pseudomonal also.
Good.
Opportunity for the residents. Yes. మీరు అడగండి. Internal medicine. Somebody is here? General medicine people are exempted to attend the mortality meet, exempted to answer the questions. Are they present? They are absent. Hey Farooq, general medicine residents are absent.
Define non-dissolving
Who is this
pneumonia
guy?
and non-dissolving.
You are general medicine?
Non-dissolving pneumonia. No, pulmonary.
I'm not rushing to. One second. Let me know whether the internal medicine people are here or not. మరి ఏమ్మా బ్రతిలాడుకోవాలా? How many people are here? I just want to see. Only 5 people are here. No issues. When I'm calling you, why you are not responding? Not necessary to respond. Huh? Sit down. It doesn't matter whether you respond or not. Yes. Yes, go ahead.
What is non-dissolving pneumonia?
Okay. Persistence of clinical symptoms and signs or non-resolution on radiographic picture by 50% by 50% after 2 weeks, or complete resolution of radiographic picture within 4 weeks, despite of giving antibiotics. It is non-resolved.
Whether this case comes under non-dissolving
Yes, ma'am.
pneumonia, right?
Yes, ma'am.
This case can be called as non-dissolving
Non-dissolving.
pneumonia. So what are the possible causes of non-resolution?
Inappropriate antibiotics, resistant organisms, atypical organisms, or pneumonia mimicking conditions like malignancy, atelectasis, pulmonary infraction, or any eosinophilic pneumonias.
And particularly in this case, she is an elderly.
Yes, ma'am.
So malignancies also you should consider, right?
Yes.
What is non-responding pneumonia?
Failure of resolution of symptoms.
I want to know the role of magnesium sulfate injection.
Bronchodilator, sir. She had a bronchospasm, have auscultation.
Is it a better bronchodilator?
Yes.
Huh? Yes, they are giving. That's why I'm asking.
That use that, but it has got effect on the kidneys also. But you have to monitor magnesium sulfate levels in the blood.
Have
It should be like 4 to
RFT.
7 milliequivalents, not more than that. It may land into respiratory arrest
No,
again.
if you are not having the dilators,
Yes, sir, we have-
others are there, better.
Because
See,
magnesium
better than
sulf-
others.
We gave inhalational route, sir. Bronchodilators on inhalational route. Still patient having the bronchospasms, sir. Because she is in sepsis, we can't add
Steroids. Okay.
So,
Further aggravation.
So when the patient is very bad, she is a diabetic ketoacidosis. What is the role of metformin when she is such a bad condition? Why do you want to dump metformin? What is the action of metformin? Do you think it will act immediately?
after sugar.
So what is my intention is unnecessary drugging, patient is very bad,
Metformin, it will take its own time, at least 7 weeks to start its function. Isn't it, metformin? And magnesium sulfate also, if you give magnesium sulfate, you have to monitor the levels in the serum. Otherwise, it may land into respiratory depression, respiratory arrest finally, and also something like a patellar reflex is lost and urine output will come down. These are the things because we commonly use in eclampsia cases magnesium sulfate. We monitor all these things well. Before giving a next dose itself, we'll see the urine output and patellar reflex and the respiratory rate also. So for that sake, I'm just telling that for completion's sake. That's what I can. Huh?
Ma'am, in this case, we are given the only stat doses, madam. Why? Because it's stat doses only. There is a no continuous dose for this case. Why? Because we are unable to give the steroids. Patient is in the severe spasm. That's why we given the magnesium sulfate. In our cases, OBG cases, we will give up to the 5 grams and 10 grams, madam. No, we won't give that much, madam. Only 2 grams only, madam. If it is not responding with the 2 grams, max we can give up to the 4 grams only, madam. After that,
Respiratory depression. It will cause respiratory depression. Actually, we are very much worried about the magnesium sulfate because in the event of eclampsia, we are closely monitoring the respiratory depression. Already she is a respiratory compromise,
Sir, eclampsia we will see in pregnancy, sir. This case is non-pregnant.
No, not that way. Because
yes, sir.
respiratory, it will cause depression.
Yes, sir. Sir, we are given only the 2 grams, sir. With the 2 grams, we
2
can't
grams
see.
Also, the convert you can give, but other drugs are there,
Sir, in the GINA guidelines also, if the spasm is not resolving, first drug is the magnesium only, sir.
Okay, sir.
That's what. So magnesium is the first drug, 2 grams we will give up to the 20 minutes. Maximum we can do that. We can repeat up to the 4 grams only. No more than the 4 grams we won't give in a bronchospasm, sir. And second question, sir, you ask metformin, sir. Actually, for this case, what happened is, in spite of giving the insulin drip also for the nearly 2 days also, all the time blood sugars are very, very, very high. So then we went to the retrograde. What is the really thing happened for this patient? And we asked the sending referral doctor, we asked them, what the thing happened is, patient was taking the betamizole nearly 20 days. So all the steroids, they are given steroid abuser, that's the sugars are very shoot up. In spite of, I asked the sir, Professor Anand sir also there. Sir, I asked the regarding that the sugars are not coming down, what is the possibility? Then sir told, sometimes if we add the metformin, that will increase the sensitivity of the cell to take the glucose, so that sir advised to add the metformin.
Yes, metformin increase sensitivity. Yes.
Yes,
At this juncture, that's what he wants.
yes, sir.
Anyway, good. You have taken advice from the Anand sir.
Yes, sir. Because sugars are not even coming down, sir. First 3 days,
Is
sir.
it documented?
Yes, sir. Document every day. They are only
Good.
followed. They are all followed. All the scale was followed by general medicine people only, sir.
That's good.
Yes, metformin increases the insulin sensitivity. So that we should add. But it action to establish takes about 1 week. Not immediate, it will start.
Yes.
That's what Okay. Maybe infection-induced resistance to the insulin.
Maybe that's the
Septic
second part, madam.
focus could be the cause of resistance
Ongoing inspection.
to insulin. Yeah, that could be also resistance to insulin. That is because of septic focus. Unless you remove the septic focus, insulin will not respond.
Yes, ma'am.
Also, okay.
Thank you, ma'am.
Yes, anybody? General medicine residents? Residents, yes.
One question, ma'am. So since the patient is a known old pulmonary COX patient and he is currently having same respiratory symptoms and same scenario similar to that of a pulmonary TB. So why did you start ATT later rather than earlier? And because I am asking now because since sir told that patient was already on betamethasone for almost 2 years. Could
20 days. 20 days.
20 days. Okay, okay. So did this have any suspicion regarding a relapse of PT?
Sputum CBNAT came to be negative, sir, on day
can be
2
negative.
itself.
It can be negative. See, I am asking why didn't you suspect could be a TB relapse in the first case or start ATT in the day of admission itself? Why can't you? Just a rationale. It's not that why didn't you start? I'm asking.
In the culture itself, we isolated the organism. So we kept the antibiotics according to culture sensitivity, but the patient is not responding, sir. So empirically, we started ATT.
Actually, for starting ATT also, the rules and regulations will not accept unless it is positive for bacilli, isn't it? Positive for AFB, then only, otherwise they don't give medicines also from the center, from this clinical suspicion also can give, they say, but it should be positive then.
No. Anyway, they are the experts. Pulmonology people.
Ade kada.
They are the experts as far as.
To support the scope, we tried for the 2 times, but the patient didn't support it. We tried, yeah, that's why it's in the second time also induced sputum we have sent for the CBNAT. At least something is came positive, like the second time also CBNAT was sent. That also came negative. So at least some positive is there, we can add the ATT. But first time came as a clip, second time also negative, sputum negative. We planned for the bronch, and bronch patient was not cooperated, so we abandoned the procedure. So if you have done the bronch, maybe that may be good. But to the bronch also, we have to intubate the patient. For the bronch purpose, we can't intubate the patient. Attendance was not aggressive. Even for the suspect the fungal, we want to send the galactomannan. That cost itself around 6,000. We explained that attendance, please do the test. For that also, they are not cooperate. That's why empirically I added the itraconazole on the day 3.
There's a big cavity in the lung.
Yes, sir.
What are the contents of that cavity?
So that may be the necrotizing material, sir.
In other words, is it pus?
No pus, sir. In cough, only white color sputum is coming. There is not even a green color change in foul smelling. Nothing.
The abscess might have walled off.
More walled up.
Why did not take the opinion of the thoracic surgeon?
Necrosis only, sir. Repeat CT also showing necrosis, but there is no clear-cut cavity with airspace lesions are not there, sir. Cavitations only.
In the CT also, you're able to see white shadow peripherally and centrally there is a cavity there.
Yes, sir, cavities.
The body is trying to wall off.
Yes, sir.
And I don't know. You are the expert. With the lobectomy will help in this case.
For this case, we are unable to do this one.
I mean, of course, general conditions will not permit.
Yes, sir.
Why did they give this cortisone for 20 days outside?
Sir, all unfortunate, very bad for our pulmonology cases is everything exacerbation or breathlessness. They will first give this a betamethasone only, but then only with not responding, then only they will come to us.
For a simple cough, they give cortisone.
Sir, outside that's a small tablet, 75 paise. Strip is around 9 rupees. Betamethasone. Even also patient address, they are not revealing. In spite of we have to go on who is sending the case, then only they are telling. They are not telling. We have to ask the particular very small weight tablets have you taken on, then only they will reveal.
She is not a known diabetic.
Not a known diabetic, sir.
Any resident? Yeah, good.
This is a case of patient had septic shock, the foci being necrotizing pneumonia patch, right? So on presentation, patient was in shock?
No. Her
So
BP
even with
130, 80.
inotropic support, when the shock didn't improve, could you have given methylene blue? Would it have made a difference maybe?
We didn't escalate the vasopressors. Even with NORAD 4 ml per hour, her BP 130, 80, 120, 80. Without any
So single
vasopressors,
inotropic support, BP was sustained. So
yes.
okay.
So we didn't.
They're happy. What is her answer?
Maybe if the inotropic support needed at a higher dose and the shock was refractory, then methylene blue was like a last ditch effort, sir, in septic shock.
In this case, it is not refractory.
Minimal inotropic support, like triple inotropic support needed, that severity is not there maybe.
Methylene blue indicated only in refractive cases, sir. Even with triple inotropes like NORAD, vaso, adrenaline, if the patient BP is not improving, then we can try methylene blue, sir. In this case, with only NORAD with 4 ml per hour or 5 ml per hour, her BP into 130 or 120, sir. So methylene blue
What's
is
the
not
mode of
necessary.
death in this case? What is that you have written in the cause of
Sepsis
death?
with septic shock, secondary to necrotizing pneumonia.
You have mentioned septic shock. Finally.
Yes. But
Huh?
it is resolved 2 days before death, sir. NORAD completely stopped on 9th, sir.
Hmm.
On day on the
She has recovered. He or she?
she, sir.
She has recovered from
Yes,
septic shock.
Yes.
Now, what's the cause of death here?
Necrotizing pneumonia with sepsis.
Mala sepsis. No more sepsis. She has recovered.
Yes.
Huh. Hmm. So, sepsis per se cannot kill the individual. Either it has operated through shock or through some other mode. But sepsis per se, as it is. What do you say, sir?
Was first initially completely recovered, sir. After starting the ETT recovered, but on the day morning, suddenly she was hypotension and desaturated. What happened? We thought a secondary bugger came like that. We thought, sir. So we want to plan for intubation, but attendants they don't
Sudden
know. hypotension, and we done the ECG. The ECG there is no AF and no cardiac event. Look like it's a second infection like that. It is look like, sir. That's why we. Yes, sir.
Finally, we are back to septic shock.
Sir. Reason for that one is necrotizing pneumonia. Sir.
Madam, మీరేం చెప్తారా?
Maybe they must have stopped NORAD drip, maybe. Suddenly until that time she recovered and suddenly she stopped, means sometimes NORAD drop, they must have stopped. maybe some block is there.
No,
maybe.
embolic phenomena due to sepsis, septic. That
Septic,
may
maybe
sudden
that could be
death.
the cause for
Is
that.
it correct?
Okay. Actually, I know it's over, no? From general question I'm asking, do you advise the people to take influenza vaccine regularly to prevent such type of incidences? Do you advise anyone? Influenza vaccine for the people? Pneumococcal vaccine also. So the people who are more than 60, they have to take that vaccine. But I was trying to take that vaccine. I'm calling my husband to come together, we'll take. He's refusing. So I'm also not going like that.
No. We'll give you if you want influenza vaccine. Don't call him.
Since many days, no, I'm thinking of taking a
We are here. We are experts.
vaccine. But think you come together, we'll go
We
like
give
that.
you
I'm asking.
influenza vaccine,
But in spite
pneumococcal
of several
vaccine.
times, he's not coming, so I'm not going. Like that. it
Anything
is.
from residents? That's it. Yes, good call. Yeah, one more girl.
By day 12, patient counts have been improved, patient is off NORAD and patient hypokalemia improved. Then what is the cause for sudden desaturation on the day? Have
Not
you
just improved leukocytosis.
By the day 12, counts has been came to 11,000, sir.
Hmm.
And antibiotics have been escalated. Have you ruled out other causes for sudden desaturation and shock?
No,
Acidosis.
patient got desaturated around 8:30 or 9. Cause of time of death is 9:25 a.m. They didn't want to intubate the patient. So,
No, her question is, what is the reason for sudden desaturation?
maybe septic emboli.
No, your expert opinion.
Yes, sir. There's maybe the one possibility is the septic emboli, sir. So we second one suspected the new cardiac event, but the new cardiac event is not there in ECG. Nothing is there. So we
Emboli
suspect,
to the cardiac, coronaries.
but changes has to be there, no, sir. That's it. Leads are told. We connected the.
Emboli can be elsewhere, only coronaries.
Yes, sir. We first
Can be in the
suspected.
brain,
Maybe, sir.
cerebrovascular.
Maybe, sir. Possibilities are there, sir.
I do not know. You are there.
Yes, sir. Possibilities are there, sir. They are not denying. First,
So
first
her question
possibility.
is, what is the reason for sudden?
Yes, sir. First possibility is the septic emboli, sir. Why? Because their source for the necrotism material is there. So septic emboli is the first possibility, sir, in this case.
How to prevent it?
We have to prevent the infection, sir. So we started everything for this case.
Yes. Who are there? Illavre? Faculty. Oh. Okay. Okay, Amma. Thank you.
Thank you, sir.
Yeah, you can applaud. Next, who is that? No invitations, you have to run fast.
Okay.
Good afternoon, sirs and ma'ams. I am Dr. Bhavya, third year postgraduate department of OBGY. I am going to present maternal mortality of Induvadana patient. My moderator is Dr. Revati ma'am, professor and HOD of Department of OBGY. Our case was admitted on 17/12/25 at 5 p.m. 5 p.m. Date of death is 20/12/25 at 4:19 a.m. The cause of death is refractory ventricular tachycardia with cardiogenic shock with sickle cell hemolytic crisis and thrombotic crisis, dilated cardiomyopathy with severe left ventricular dysfunction with reduced ejection fraction of 35%. Coming to the case details, a 28-year-old antenatal mother by name Induvadana, wife of Suresh Kumar, resident of Jalmuru, who is a housewife. She is an unmarked primigravida with 34 weeks of gestation with IOFD with no case of sickle cell disease. She presented to ER at 5 p.m. With severe anemia, severe joint pains since 2 days and absent fetal movement since 1 day. Her LMP is 21/4/25, EDT is 28/1/26. Tifa is normal study at 24 weeks of gestation. She was referred from a private hospital, Narsanpeta, in view of sickle cell crisis, intrauterine fetal death, hemolytic jaundice for further management. History of present illness, she was apparently all right until 16/12/25. She was admitted in the private hospital for blood transfusion in view of anemia, HB 7.5 grams, started to have generalized body pains, fever, vomitings 3 episodes. These are non-bilious after receiving the transfusion on 16/12/25. On the same day, FHS was present. On next day, she complained of absent fetal movements and ultrasound was done and it was diagnosed as IOFD on 17/12/25. Then she received a tablet mifepristone 200 mg at 4 p.m. On 17/12/25 in the process of induction of labor, and then the case was referred to GEMS. Her obstetric history in first trimester, it was uneventful. Her HB was maintained as 8.5 grams. In second trimester, in view of chronic anemia and recurrent blood transfusions, physician deferred the case to hematologist where HB electrophoresis was done and HbS levels were 74.4% and the report came as sickle cell homozygous. Hematologist advised continuation of pregnancy with high-risk counseling to the patient. Incidentally, spleen was not visualized, autosplenectomy on ultrasound. In this pregnancy, she had 4 blood transfusions. 4 units of PRBC transfusions were done on and off. Past history, She is a known case of sickle cell since 5 years of age, but labeled as thalassemia and treated at Hyderabad, but no documents are available. She had history of frequent blood transfusions since childhood, around 2 to 3 per year. Personal history, she takes mixed diet, normal appetite, sleep, regular bowel and bladder habits, no addictions or allergies. Family history, nil significant. General examination, pallor and icterus are present. Febrile, pulse rate 86, BP 130/90, respiratory rate 32 per minute, SpO2 is 88 on arrival. CVS was heart and lungs are clear. Her pre-pregnancy weight was 45 kg, present weight is 57, weight gain in pregnancy is 12 kg, BMI 22.28. On obstetric examination, inspection, longitudinally ovoid, linea nigra, stria gravida were present, no scar sinuses, no swellings or no visible pulsations, palpation uterus corresponding to 32 weeks, relaxed, cephalic presentation, fetal heart sounds are absent. On pervaginal examination, external genitalia are healthy, cervix soft, posterior, uneffaced, os closed, presenting part is vertex high up and pelvis gynecoid and adequate. My provisional diagnosis is primary with 34 weeks of gestation with intrauterine fetal demise with sickle cell crisis, hemolytic crisis and painful crisis. In ER, patient was attended by general physician team, critical care team and obs-gyn team. Patient case was admitted and shifted to MICU on 17/12/25 at 9 p.m. for further management. High risk consent was taken. Course in the hospital, oxygen support was given, IV fluids, injection meropenem 2 gram stat dose was given followed by 1 gram, injection Pantop, injection Lasix 20 mg stat dose, ketraloc, tablet ketraloc 30 mg stat dose, tablet hydroxyurea, injection Tramadol, PCM infusion was kept SYS and GR-based monitoring was done and strict IO charting was done. Investigation, CBC, HB 7.4 grams. On the date of admission, HB was 7.4 grams with platelet count of 2 lakhs and WBC count was 15,000. On 18th, her HB was dropped to 6.8 grams with platelet count 1.47 lakhs and WBC count 20,000. On 20th, her HB was dropped to 4.2 grams with total counts 19,000 with platelets 95,000. Her sickling, here again electrophoresis was conducted and her sickled RBC was 63.1 with peripheral smear showing target cells, sickle cells and teardrop cells. Her LFT report, total bilirubin is 6.8, direct bilirubin is 3.2 mg per dl, SGOT is greater than 750, SGPT is 547 units per liter, remaining are normal. 2D echo was done and that time ejection fraction was 50%. Her thyroid profile was normal. CRP levels are raised, that is 162.59. D-dimer levels are greater than 10,000. In coagulation profile are normal. Serum fibrinogen levels are 644 milligrams per dl. RFT was found to, RFT was normal. In CUE, protein 2+ is present and blood is positive. Case seen by critical care team and general medicine team on 18/12/25, that is day 2 of admission. Continued same treatment as in given in MICU, added 1 unit PRBC, advised 1 unit PRBC and 2 FFP transfusion, injection N-acetyl cysteine 600 mg IV, added 12th hourly and plan for delivery of baby. Case was shifted to labor room on 18/12/25 at 2:30 p.m. by critical care team advice as patient is hemodynamically stable, further progression of labor and plan for blood transfusion in view of anemia. At the time, our vitals are stable. SpO2 is 98% on 4 liters oxygen. BP was 130/90, pallor icterus is present. One PRBC transfusion on 18/12/25 as advised by critical care team was kept. Transfusion was started at 2:50 p.m. Patient developed chills at around 4:45 p.m. after 2 hours, so blood was stopped immediately. Sorry, ma'am. So blood developed chills at 4:45 p.m. after 2 hours, so blood is stopped. At that time, vitals are pulse rate is 108 beats per minute with respiratory rate 45 per minute and SpO2 is 90% on room air. Immediately 8 liters oxygen was kept and temperature was 101. Patient complained of severe joint pains and back pain since from 6 p.m. In view of reaction, general medicine referral was done on at 18/12/25. They advised injection hydrocortisone 100 mg IV stat was given. They advised for termination of pregnancy, strict vitals and SpO2 monitoring, and need NIV support if saturation deteriorates, and advised chest X-ray and 2D echo. In X-ray chest, cardiomegaly and pulmonary edema are present. Repeat 2D echo was done on 19/12/25. In that, global LV hypokinesis, severe LV dysfunction, left ventricular ejection fraction 30 to 35%, mild TR, mild no PAH, and trace pleural effusion is seen. In view of chest X-ray changes and 2D echo changes, cardiology and pulmonology referral was done. Cardiology referral was done on 19/12/25 at 11 a.m. They advised to stop IV fluids and allowed oral fluids, and advised injection Lasix 20 mg twice daily, tab aldactone 25 mg once daily with tab metaxel, tab Sidmus once daily, tab Defatab 10 mg half tablet once daily, and they told to shift the case to cardiac ICU after delivery of the baby. Pulmonology referral was done on 19/12. Patient complained of SOB on exertion. So pulmonology referral was done. At that SpO2 was 85% on room air, 99% on 8 liters of oxygen, pulse rate 96 beats per minute, respiratory rate 26 per minute, with bilateral Krebs right more than left, with decreased breath sounds on left side. So they advised nebulization, and they told to plan CTPA if no improvement. Case seen by medical gastro team in view of dearranged liver enzymes. They diagnosed as sickle cell hepatopathy precipitated by sepsis. They advised to tab Udiliv, injection N-acetyl cysteine 2 grams in 100 ml NS IV 6th hourly, followed by N-acetyl cysteine 2 grams in 100 ml NS IV 12th hourly, serial LFT monitoring, serial PT with INR, APTT monitoring, anti-HIV and HIV. Obstetric management. Treatment to the patient going synchronous with other specialties. The process of induction of labor was started with medical management. Tablet mifepristone 200 mg given at 4 p.m. on 17/12/25. Foley's induction was kept at 3 a.m. on 19/12/25 along with tablet misoprostol 25 mcg PV kept at 3 a.m., 9 a.m., 1:30 p.m., 5:30 p.m. and 9:30 p.m. on 19/12/25. After the last dose at 9:30 p.m., cervix dilatation was 3 to 4 centimeters with TENS BOM. We are expecting delivery after 2 hours. Until this, the patient was stable. At 12:30 a.m. on 20/12/25, patient developed tachycardia, tachypnea, drop in saturation to 85% on 4 liters of oxygen, remained the same on increasing to 8 liters oxygen, immediately informed to critical care team and anesthesia team and reviewed by them. At that time, vitals are pulse rate is 120 beats per minute, BP 80/50, respiratory rate 42 per minute, SpO2 85% on 8 liters oxygen. GRBS was 56, injection 25% dextrose, IV start given, and case was shifted to MICU. Case shifted to MICU at 20/12/25 at 12:45 a.m. Patient suddenly developed refractory ventricular tachycardia and became unresponsive with pulse rate of 135 beats per minute. Respiratory rate, SpO2 and BP are not recorded. Then immediately high quality CPR was started with injection adrenaline 2 cc IV stat, with injection amiodarone 300 mg IV stat given, synchronized cardioversion of 200 joules. Patient revived after 7 cycles of CPR and started on mechanical ventilation. BP 70 mm on palpatory with NORAD 25 ml per hour with vasopressin 2.5 ml per hour. Pulse rate is 140 beats per minute. Respiratory rate 16. SpO2 95% on mechanical ventilation. FiO2 100%. PEEP 5 centimeters H2O with tidal volume 400 ml. Patient attendants were counseled regarding mortality related to sepsis, septic shock, dick embolism, hepatic renal failure, MODS and cardiac arrest. Explained about ICU stay, intubation, ventilator, central line and blood transfusion. Patient attendants want to continue the treatment. On critical care advice, 1 unit PRBC transfusion started at 3:20 a.m. on 20/12/25 in view of HP 4.2 gram %. BP not recorded. Pulse is 140 beats per minute. Respiratory rate 18 per minute. SpO2 95% on IMV. FiO2 100% with B 5 centimeters O2. After 30 ml of blood transfusion, patient suddenly went into refractory ventricular tachycardia. So transfusion was stopped at 3:40 a.m. on 20/12/25. At 3:40 a.m., patient suddenly went into refractory ventricular tachycardia and became unresponsive with pulse rate 135 beats per minute, BP, respiratory rate, SpO2, carotid pulse not palpable, pupils mid-dilated, not reactive to light. 4 cycles of CPR immediately started with high quality CPR. 4 cycles of CPR were done. Despite of all these measures, cardiac life support, and pupils dilated and fixed. ECG shown asystole, hence declared dead at 4:19 a.m. on 20/12/25. Primary cause of death is refractory ventricular tachycardia with cardiogenic shock with sickle cell hemolytic crisis, thrombotic crisis. Secondary cause of death is sickle cell crisis with dilated cardiomyopathy with severe left ventricular dysfunction with reduced ejection fraction of 30 to 35%.
Good.
Thank you, sir.
Yes. Residents? Questions from residents? Yes? Sorry. Mic it fast. Fast. Slow down.
Why wasn't the fetus delivered already there? It was diagnosed as intrauterine fetal death. Why wasn't it delivered immediately after coming?
IUFD is not an indication for cesarean section, and for IUFD should be delivered vaginally, and it is a fresh IUFD, and it is not a cause of sepsis or DIC in this patient, because for an IUFD to develop into DIC, it takes about 4 weeks, and for any sepsis foci to form, it at least takes 7 days. So generally mode of delivery preferred in this case is vaginally. So we started, after IUFD confirmed, we started with vaginal induction of labor, and cesarean section. To conduct cesarean section also, patient is in active crisis and HP is not maintained above 7 grams, and anesthesia risk related to hypoxia, acidosis will be there. So patient may land into pulmonary embolism and cardiac arrest on table. So we prefer vaginal mode of delivery.
But prolonging the not delivering also can be the cause for
not delivering may be caused, but to do
Not
cesarean section in this case also, patient is in active crisis, and when patient is in crisis, when HB is not maintained above at least 7 grams, patient on table may land into cardiac arrest and die. So that's why we didn't take it. Emergency delivery.
Okay. Let me see the anesthesia team. 1 second. This is the anesthesia team. How many of you are there? How many of you are there? She says you are risky. That's what she said. When she asked why you are not delivered section, they said anesthesia. What do you say in this case? Is there a problem in giving anesthesia? Huh? Mikey, అమ్మా.
మైకి నేను మాట్లాడతాను కేసు
Madam,
నేను
last.
మాట్లాడతాను ఓకే
Last. Yes.
As patient is having tachypnea and distress, it is not possible to give for regional anesthesia, sir. We can go for GA with consent for blood transfusions and standby defibrillator and everything, sir. We can manage with GA, sir, with high risk consent. My question is, when patient has arrived, they have done the blood transfusion. They told some reactions that has happened. Did you evaluate the reason?
Not once, twice.
Twice, sir.
Every time, whenever she's trying to give a transfusion,
yes, sir.
there is a problem.
Even outside the transfusion, she has got the reaction. So what is the reason?
Crisis, hemolytic crisis.
But immediately after the transfusion, patient is landing into...
Actually, the patient was all right. When she go to the private doctor, 7 grams hemoglobin, they gave everything fine. And she went to a private doctor, they gave a blood transfusion because of anemia. After giving blood transfusion, maybe 10-15 minutes over, then she started to have the hemolysis crisis. She had that.
Yes,
so because of the crisis, they stopped the blood transfusion, and baby was all right that time. And after that, referred this case because of the crisis. And after the next day, what happened? There was a IUD. Baby died the next day. So they referred this case here for that. So she started to have this one with the after blood transfusion. So that is maybe because this is a case of sickle cell anemia. They'll have the genetically and inherently the cells will be fragile. Their RBC will be fragile. So because fragility of the RBC and because of the pregnancy is a risk factor again, the hypercoagulability of the state of the pregnancy also. These are all the reasons that will aggravate the factor like hemolysis. hemolysis. So but that is the reason why hemolysis has occurred. So by the time they're asking the question, why is not delivered? Because we started the induction already. Because cesarean section is is purely of obstetric indication, not for the hemolytic crisis. Hemolytic crisis does not land into this cesarean section is one. The second thing is on table, if we decide the case for cesarean section, what happens is on the table, the chances of going for the PPH, postpartum hemorrhage, is a severe complication that occurs. This is one. The second thing is her hemoglobin after giving blood transfusion here, it came to 6 grams. 6 grams, that anesthetist will not accept the case for 6 grams. So that is not a thing we can give blood. As if we give blood, because she'll go into again hemolysis, further aggravation. Her here you saw, no? No, her, her, no, listen, listen. No, it's not like that. Listen, her hemoglobin became, listen, her hemoglobin became 4 grams. At that juncture, can we go for cesarean section? Actually, she is progressing in the labor. She was already 4 to 5 centimeters.
HB 4.2 is on third day. ma'am.
Third
So
day, third day.
immediately on arrival.
Yeah.
HB
No,
was
we can't go for that because she may land into further complications of this one. Like again, further aggravation of the symptom hemolysis will be there and
Yes, ma'am,
PPH will be there.
Means majorly it's not anesthetic.
యాక్చువల్లీ ఇది ఎలా ఉందంటే కేసు మాకు ముందు పోయి వెనక ఇలా ఉంది. కేసు చేయకపోతే అది షీ విల్ డై ఆన్ ద టేబుల్, డివోటీ విల్ అక్క ఆన్ టేబుల్. చేస్తే ఇది ప్రాబ్లమ్స్ షీ విల్ ఫేస్ ద మెనీ ప్రాబ్లమ్స్ లైక్ దట్ ఇట్ ఇస్. సో యాక్చువల్లీ ఇట్స్ అ బ్యాడ్ కేస్, రియలీ టెలింగ్ దట్ ఇస్ అ బ్యాడ్ కేస్ రియలీ. Hemolytic crisis with associated with
Her question is it transfusion induced sickle cell crisis?
That's what.
Yes, sir.
Every time whenever they are giving
No, it can be transfusion induced sickle cell crisis. At the same time, she has a septic focus also. She went with a fever there and dehydration. Because of the fever and all, they have dehydration. All these are triggering factors for sickle cell crisis. Sickle cell crisis 3 types, no? Because hemolytic crisis, it can be like thrombotic crisis, and also it can be this one. All these triggering factor is dehydration. Dehydration is triggering factor for this. Dehydration,
Any other
septic
resident?
focus. No.
This
Case,
Sir,
prior to the
answer the
prior to the admission,
One
she
question or you
went.
want to give answer? No.
In
We
this
want
case,
questions. No answers. You want only questions, and some of you
in
can
this
answer.
case, autosplenectomy was already
Sarah
done.
wants to ask?
So
Yes.
Yes, somebody wants to ask. Good. Sir. Residents.
So autosplenic. Yeah.
Residents, please.
Yes.
Patient was in heart failure initially. She has stress cardiomyopathy. Again, induction of labor could be proarrhythmic because it increases the load and hypertonic circulation. That might ventricular tachycardia might have been because of that.
yes, but we have to induce the labor for IUFD. We have to deliver the baby. If doing section is much more stress to the patient, so we have induced.
Again, given a proarrhythmic state for the patient because sudden decompensation is because of ventricular tachycardia.
You mean to say induction itself is responsible for this?
Under heart failure basis, again an induction of labor is a stress factor for the heart. So it might
Absolutely.
cause any proarrhythmic state because of which she had thrown ventricular tachycardia.
And she is surrounded by so many complications. Actually, this patient is.
No, what she says, when there is a cardiac issue, induction is a load, adding load onto the heart. That's what you want to say? Yes, good. Nothing wrong in it. Anybody else? Yes.
She has cardiomyopathy only after starting the induction. Induction is over, she's progressing, almost about to deliver to this one.
No, that's what she's saying. So after start.
Cardiomyopathy,
Yes.
normal before induction.
Yes.
What could be the source of sepsis in this case?
Yes, madam said sepsis. Yes.
Sickle cell anemia, people will have easy infections.
No,
They
there
are
is
prone
no.
for more for
There is a
infections.
source of sepsis. Yes.
Yes, sir.
Please identify the source of sepsis. A presumption.
IUD
No,
may be
no,
the
no.
but here IUD is not the source of sepsis. Patient is already
No, no, no.
blood transfusion reaction
Sir,
was
prior
happened.
to IUD, she had infection,
Infection
101 fever. For that only she went to a private doctor. She had the
No,
treatment
what is her
there.
status in the GEMS hospital? With infection, without infection?
So with infection only she has come. By the time she came here, it was
levels are elevated,
22,000.
Okay,
But
one
we-
at a time, please. Yes.
CRP levels are elevated, sir, but fever profile came to be negative, sir.
In
Yes.
case if she is in shock, why hasn't the serum lactate been monitored? Means how did you monitor whether the shock is progressing or responding to the treatment?
See, LDH levels are normal.
Serum lac,
Serum
whether the
lactate-
organ perfusion is adequate or not is based on serum lactate levels, whether she is in acidosis or not. So how has the shock been monitored?
We referred to critical care. Actually, they didn't advise anything. The case was already seen by critical care, seen by physicians, seen by many people.
Cardiology? Yes.
Yes, they have seen cardiologist with a cardiac problem, cardiologist. Everybody has surrounded her. Everybody has seen the case. That's what I'm telling you. And
Nice thing.
one more thing I just want to add is because she has got autosplenectomy. Once autosplenectomy is there, immunity will be less. And also that autosplenectomy, the spleen cannot filter any toxin, something like
The hemolysis
something
phase
they
has been
cannot
shifted to
filter.
intravascular
What are the
No
antigens that are coming from the
I
blood,
thought
along
there
with
is
the
no
blood?
spleen.
Because the autosplenectomized case it is.
No spleen, sir.
In case
Huh?
the spleen
Yes.
has been, means in case autosplenectomy is done, has she been vaccinated against capsulated organisms?
Yeah, she has been vaccinated for meningococcal and pneumococcal and Hep B vaccines.
Out-
Haemophilus influenza
out-
vaccine.
outside,
In
outside.
outside hospital, she has been vaccinated in 5th month itself.
This woman, she is having albuminuria. She is having elevated liver enzyme. Why didn't you think of HELP syndrome? And even slight elevation of blood pressure, low platelet, not much, of course.
Platelet counts are normal, sir.
Normal, they were coming down. At the time of death, it was less than 1.5. Okay, but she was even having excessive weight gain, and she is a risk candidate for developing preeclampsia. Given the background of elevated liver enzymes, IUFD, and proteinuria, why didn't you think of the possibility of severe preeclampsia, HELP syndrome, IUFD? And in this case, early delivery could have saved the life.
Midsection?
Yes, if necessary.
Yes, madam. Early section and delivery.
The dictum says that HELP syndrome mandates delivery at the earliest.
Yes, Sagar.
Can you
No, anyway. Anyway, madam.
So because of that, because of hemolysis and sickle cell crisis was the thing, we were going in favor of a sickle cell crisis only. Because of that, we anticipated PPH and other complications. We didn't go for that, and we tried for vaginal delivery, and she was about to deliver also. Before that mishap happened.
Anything you want? Pulmonology team.
Doctor has already started induction. Generally here, you thought that the induction will continue and it may progress. That is the reason you are not telling them. Already they have started induction at that place before referring this.
For this case, X-ray you have?
X-ray. You want X-ray?
Yes, the X-ray was done, or it was not?
Anyway, she has not projected.
Sir, X-ray findings are totally objective, sir. It is different from the person to person, sir. What we are saying is, they are telling it's a pulmonary edema, but I can say it's a patient was presented with a crisis. So whenever the crisis is, the first organ is going to be involved is the lung.
Yes,
So
sir.
either the secondary pneumonia is there or not, we want to see. That's the first one.
Over that, she has history of multiple transfusions recently.
Yes, sir. That's what.
Could be a trally also.
Yes, sir, trally. Second option is the trally.
Trally,
And
yes,
third thing is there is history of this plenty of transfusion. First we had to try it is the exchange transfusion, not the blood transfusion. We have to remove the blood and we have to give the
Exchange transfusions.
Exchange transfusion has to be done. And second thing is there's a case of mislabeled as a thalassemia in spite of sickle cell crisis. So we should try up the chelating agents so that can reduce the burden on the heart. And second thing, as the sir mentioned, initially the EF is 50%, later was gone to the 20. So 30, sorry, whatever it is there, it's LV dysfunction is there. So we should go try for the C-section rather than the induction in this case. So that may be the less burden to the heart. So we could try the first one is the exchange transfusion that may, any general medicine is there, they can give the better options, sir. Because in this plenty of dumping the blood, exchange transfusion. First you have to remove the blood. How much blood is the first you have to remove, then you have to give the fresh blood.
It's a big case for exchange transfusion. We have severe hyperbilirubinemia, jaundice, as well as sickle cell crisis. Her HbS is about 60%. More than 20% mandates exchange transfusion.
And one more thing, in this case, we can try off steroids, sir. Why? Because it's a hemolytic crisis.
Yes.
Vascular crisis. First, we can give it steroids in this case.
For your cases, people should not use.
Sir, we give only the monitoring dose of steroids. We won't give the excessive steroids, sir. But because this is a clear-cut indication of. Sir, steroids we can give this one to activate the receptors.
Controversial.
Any resident regarding exchange transfusion, sir says we should have given exchange transfusion. What do you say?
Yes, sir.
Exchange transfusion you should have done?
Yes, sir.
Huh?
Because after transfusion, patient is
That's right.
more going
Madam.
into hemolytic crisis, no, sir?
No.
Sir,
Madam,
after every...
we need more blood in the patient rather than in the blood bank. He is at 6 grams and 4. Sir, our hemoglobin is 6 and 4 grams. What is there to remove?
Sir,
There is nothing to remove. You have to add.
No, sir.
Sir, we have to
Even at the level of 6 grams.
Yes, sir. Definitely, exchange transfusion is the better condition for this case, sir.
No. We have. There is that.
We can remove the
Whatever is there.
sickle cell RBC and replace it with normal RBC, sir. And also her bilirubin will also come down.
You are right. Oh, this is a chest X-ray, sir.
Sir.
Yeah. Nice thing. Hey, you're Oh, yeah. Yes, sir. 5 minutes to go. We are going to close it.
Yes, sir. Sir, at what day this X-ray? Day 1 or
On 18th,
Huh?
post-transfusion, sir.
Post-transfusion? So after admission of how many days?
1 day.
Day 1 only. Next serial X-ray? Serial X-ray?
18th only we have done X-ray, sir. On 19th we have referred the case to you, sir. On 20th, case.
In this X-ray, I can see only this cardiomegaly is there, right? Minimal pleural effusions. Left side also I can see the minimal. Cardiomegaly main part in this X-ray.
They refer to the pulmonary people in view of SOB.
I am only pulmonary people.
Yes, sir.
No, somebody must have given opinion, some opinion from your side.
Sir, we advise then CTPA, sir, because I elevated this thing. Sometimes what will this vascular concentration thrombi will form. The suspected sickle cell crisis thrombi will form in the small vessels of the pulmonary vessels. That's why we advise the
Acute
CTPA.
chest.
Unfortunately, patient is not in condition to perform the CTPA.
Nice.
CTPA was advised, sir.
Yeah, advised by them.
Yes, sir. On 19th it was advised, sir. On 19th night only patient condition deterioration, sir.
Patient was not in condition, that's why.
Okay, sir. We will conclude this session.
Sir, one doubt, sir. Sir, why can't be the TACO? TACO means transient-assisted cardiac overload might be possibility because all deterioration event starts after transfusion only. Before transfusion, be absolutely stable.
Yes, sir.
The cardiac overload also, that cardiac source, the cardiomegaly source. Maybe it be purely transient-associated death.
Transfusion associated cardiac overload.
Then,
Possible.
Possible. Then why it will happen? Because maybe transient-associated, it is after how many hours it happen?
After transfusion.
During transfusion.
Because already severe anemia, better to give full aliquots. Better start with slow aliquots. Maybe it will slower small volumes.
I agree.
So in
As a-
small volumes only we have started, sir. Slowly only we have started.
No,
now.
I mean what? Not means if patient needs around 350 ml, you can give on 150 ml. Later after 12 hours, can give after 150 ml. That's better.
Only 50 ml was transfused, sir.
Water maybe because careful monitoring needed, sir. Actually, this is actually
At 2:55 we started the transfusion, sir. At around 4:45 patient complained of chills, sir. So we immediately stopped the transfusion.
Because
sir.
Taco
At around 8
already,
o'clock we have taken the X-ray, sir.
because already IUD is there. IUD itself causes for the DIC. Already IUD itself causes infection. Infection will aggravate the Taco. Transfusion-assisted cardiac overload. Be careful. Better to give transfusion in this like patient. You give in ICU maybe.
In ICU only we have kept, sir, at 4 drops per minute, and then escalated to 6 drops, then 8 drops, like that. Very
Before
slowly
itself,
we have
half an hour before
transfused.
means it will be any tachycardia, anything, better to stop immediately. Can stop now, can prevent the death.
If tachycardia was there, sir,
Then
while
that
patient
that is a trigger point that you have to stop the
immediately we
transfusion.
stopped the transfusion, sir. At pulse rate was 108 at that time immediately we stopped the transfusion, sir.
Later cardiology opinion, it shows like better to show the cardiology opinion. Cardiology.
Earlier than
That's
that.
okay.
The time is up.
Okay, thank
We
you,
are
sir.
closing
Thank you.
it for today. Thank you very much. And this time, the prize goes to General Medicine Department for their 2 nice questions. For one question is sudden desaturation. Who is that girl? What is the reason for sudden desaturation? I do not know. Second question I forgot, but anyway. Thank you. Thank you all.
Thank you, sir.